what would happen is if a child would swallow one and then maybe a little while later swallow another one, you can get these magnets floating around in the gastrointestinal tract. And if they get close enough to each other, they'll stick. But if they're in two different loops of bowel, they will attach across the wall of the bowel and they will pull each other with such power. They will eventually rupture, like make a hole.
They'll
in
eat
the
through.
intestine.
You die.
Yeah, that's dangerous. People will die from that.
Hello. Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My return guest today is Dr. Ben Gerber. Welcome back to the show, Ben.
There you go.
Ben, you were a big hit. Ben is a general surgeon and a friend and colleague of mine. And we talked about a lot of interesting things. Our first interview, the most famous of which were compound bow accidents.
Yeah. That was a memorable couple of
arrow injuries, the day of the shark bites. Those were fun conversations. Now, today we're going to talk about a topic called GERD, Gastroesophageal reflux disease. Most people just know it as bad chronic heartburn. And we're going to work eventually into the amazing surgery you do. Mm-hmm. That helps these types of conditions when it's appropriate, obviously. So we're going to talk about GERD and heartburn today. So I've had an occasional bout of heartburn. What brings it on for me is generally tomato sauce. That's my culprit. And there's a lot of people that can't eat this or X or Y or anything. So tell me, how big of a problem is heartburn and GERD, and maybe you can tell me what's the difference between just a little heartburn that I might have from time to time and something really serious like GERD that goes on for a long time.
Yeah, I think this is the distinction between heartburn and GERD is something that a lot of people deal with, and I think we should talk a little bit about how to tell the difference between the two. And medical treatment for heartburn is one of the top 10 medications in America. Like if you go up to look at the websites about like what are the 10 medications most commonly prescribed, and proton pump inhibitors, which are typically prescription strength heartburn medications, are on that list, up there with as common as diabetes and high blood pressure and high cholesterol. Things like omeprazole and Prilosec and those sorts of medicines too.
Something like 100 million prescriptions a year. That's in the ballpark, isn't it?
Something like that, yeah.
Yeah, big deal.
So lots of people, if you make bad food choices, will just have heartburn, right? And that's like, I too much chili and beer last night. I feel like, I have heartburn. Okay. And those patients, it's perfectly reasonable and appropriate to manage that by getting something at the pharmacy and taking some Tums or a week or so of a treatment.
An antacid.
Of some kind.
Basically, we have acids and bases. The stomach tends to be is acidic.
It's pretty severely acidic.
Severely acidic. Yeah, super high. So if you take a base, a calcium or something based hydroxide or something,
all of your Tums type medicines essentially, and your Pepto, those medicines are basically basic, and they just try to directly counter the acid and neutralize the acid in the
directly.
Stomach. Yes. And then your Pepsid type medications actually work through a hormonal system that turns down the acid production in the stomach. Mm-hmm. They don't produce their effect quite so quickly. It's usually not within a couple of minutes. It takes a half hour or so for it to reach full effect.
And those are slightly older drugs.
Those are slightly older drugs, and but they also don't last for a really long time. Like typically, will last for a few hours. Right? They'll get you through a bad meal or whatever.
Okay.
PPIs, which are proton pump inhibitors, are typically they irreversibly bind the molecule in the stomach lining that actually puts acid into the stomach, and they destroy that molecule so that protein doesn't work anymore. So in order for that, those medicines last for a lot longer because the body has to actually manufacture new proton pumps in order. So those medicines are usually appropriate in people who have more persistent symptoms for longer periods of time, or more reproducible. It's like they have GERD every day and that sort of thing. And I think that typically if you're dealing with GERD every day and for weeks and so on, months, you probably should talk to your doctor about it. And then with doctor supervision, you can get started on all of these medications.
All right, so let's clarify once again. What's the difference between just occasional heartburn, severe chronic heartburn, and GERD? I assume it's a continuum from mild to severe.
And heartburn is more like a symptom, and then GERD is a disease. Right. So patients who are short of breath could be short of breath for a lot of different reasons, but that's your symptom. And then asthma is one of the diseases which might potentially cause it. So heartburn is the burning sensation in your chest. And the most common cause of that is basically having a little bit of acid exposure in your esophagus. Gastroesophageal reflux disease is a disease where a person basically is having persistent acid exposure in their esophagus from their stomach.
Okay.
And that's like a thing that happens, it doesn't matter what you ate. You're getting it all the time. And you need to be on a medication to help manage your symptoms persistently. And those patients will sometimes get symptoms that extend beyond the esophagus itself. Like if you're refluxing high enough up your esophagus, you might choke on it and then
you can taste the acid.
You can taste it. Some people get teeth problems from it if it gets all the way up into their
really?
mouth. Yeah, they can damage the enamel on their teeth. So then they get bad teeth from it. Some people will find their voice changes because they get like damage to their vocal cords, and their vocal cords start to thicken and scar a little bit, and that changes their voice, and they get hoarse.
I'll be darned. So what are the symptoms of heartburn, and when should a person care or be alarmed enough to go see a doctor about what might be GERD?
So definitely if you haven't swallowed trouble where food's getting stuck in your throat, that's a big deal. And you should talk to your doctor about it. And you probably will end up needing to have a scope done by a gastroenterologist.
Okay, so if you're swallowing, it feels like it's stuck.
And it won't go down, yeah.
Not a good symptom.
That's a problem.
What else should people worry about or be concerned about?
Well, if you're starting to have, like if you lay down at night and you wake up choking on your stomach juices and vomiting up that's a problem too. And you should probably talk to your doctor about that. And,
so a person might be lying on pillow, putting more and more pillows, right, just self-correcting, and then all of a sudden they were, hey, Jay, maybe this is a problem, and exactly. Pillows isn't cutting it anymore.
Yes.
Okay, so that's another symptom.
So for most people who have run-of-the-mill GERD, where they don't actually have a lot of regurgitation stuff, but where they're just dealing with heartburn that happens all the time, if you get on appropriate medicines with the supervision of your doctor, you'll be able to get that under control.
So when does it go from heartburn? Well, I guess GERD, as you just told me, is actually a specific diagnosis.
Right.
But when do the heartburn type symptoms progress to a point where someone should see a doctor?
So I think for most people, the point where you make that decision is that you've been trying to manage it with over-the-counter medications, and you've been taking these medications for weeks and months, and you're not able to stop.
And if you're aware enough to say, hey, gee, like you mentioned, Chilean beer is doing bad, and you're able to cut it out, right, for the most part, and then you still have the symptoms.
Right.
Like me, I got cut out the tomato sauce, and then right, it seems to be okay now.
And it's probably not a big deal for you because you're able to control it with some dietary changes, and maybe you had a bad episode one time and you had to take some Tums, and that's not a big deal. You don't have to talk to your doctor about that. But if you're like trying to change up your diet, it's not working.
It's not working.
And you're still, I've cut out all these things from my diet. I'm still having heartburn every day. You should talk to you've tried these medicines. The medicines help some, but it says on the back of the package you shouldn't take it for more than 2 weeks without doctor supervision.
There you
go.
So,
if you've been making changes and adjustments to your diet and trying to do it, you need to at least talk to your doctor about it. And sometimes you can get the medicines more economically just over the counter than you can through prescription. But at least with supervision of your physician, you probably should talk to somebody.
All right. So,
and that's GERD. And then I think GERD is also, related to hiatal hernia. So I have a clinical interest in hiatal hernia, which is something that it's a hernia, that means it's a hole, but it's a hernia through this part of the body called the hiatus. And
in the diaphragm. So the stomach
correct.
Is living mainly in the abdomen. The esophagus has to go through the chest or the correct. Thorax, and there's the skirt steak for people who eat beef. Yep. And the skirt steak has a hole in it that the esophagus goes through, and it should be a normal size.
About as big as your thumb is about how big the esophagus hole in the diaphragm is supposed to be for most normal people. Now, most people can imagine, like a belly button hernia. And if you develop a belly button hernia, you see it bulging out. But the hiatal hernia is a little bit more insidious because it bulges into the chest. So you can't really see it happening.
Yeah.
And as a consequence, people oftentimes will have symptoms associated with their hiatal hernia that may have been present for a very long time before they are able to determine what the problem is. Because in order to diagnose it, you have to be able to examine this part of the body, right? And you can't do it by physical exam. You typically have to either have an endoscopy done where they examine it by a scope, or they have a CAT scan or some other kind of imaging study done where they take pictures and they visualize the problem.
So this hiatal hernia can cause GERD?
It's one of the things that can cause GERD. Yeah, absolutely.
That's something you don't want to let that get worse, do you?
Correct. So, hiatal hernia is one of those things that will get worse over time. The size, just like groin hernias or belly button hernias, they tend to slowly grow larger over the years. So if a person has a hiatal hernia, 5 years later, it will be a larger hiatal hernia. And
they tend not to heal on their own.
Right. They never do.
They never do.
And they, with medicines, you can manage the symptoms, because for most people who have a hiatal hernia, their symptoms are GERD. And you can manage those symptoms by taking a lot of antacid medications, and that's able to control it. But it doesn't really fix the anatomic abnormality. The shape in the body is broken, and that will continue to worsen. And eventually, patients will oftentimes get worsening of their reflux to such an extent that even with medicines, it's inadequate. And occasionally I'll see situations where the hernia itself becomes so big that it starts to do things otherwise, where like the stomach can get all the way up in there and twist it over or something. So then they can't swallow because it's kinked off. Or
will it affect the lungs?
I've seen some cases where it's so large that it begins to press on the adjacent lung, and then it impairs the lung function. There's actually been studies done on this, that if you have patients who have pulmonary disease and they're being seen by a pulmonologist,
what's lung,
right? So they've got a lung, COPD, for example, right? And they have a hiatal hernia. If you do a pulmonary function test to evaluate all the characteristics of their lung function, and then you do a hiatal hernia repair surgery, and then you repeat that test a few months later, their pulmonary function will sometimes improve, because the diaphragm is first off, the lung doesn't have this organ pressing on it anymore. You pulled the stomach out of the way so the lung can expand to its full size. And then the hole in the diaphragm is repaired so the diaphragm is more functional and their breathing becomes more efficient.
Gotcha. Now, before we get into the surgery, let's talk about the various foods that are purported or associated with heartburn. Now, I keep mentioning the tomato sauce because that's near and dear to my heart. But is it true that alcohol can exacerbate heartburn and GERD, do you think?
Alcohol does. It's generally a little bit of a muscle relaxer. So it sort of relaxes your lower esophageal sphincter. For people who have sort of borderline reflux type stuff, and you do muscle relaxing type maneuvers, you're essentially going to increase your amount of reflux. Yeah.
How about smoking or tobacco?
In general, those are not healthy for you, but I don't think there's a specific association with GERD.
Gotcha. Now, apparently being overweight.
And
overweight can add to your problems.
That is true. And it's easy to understand how that works. Is that for most people, when they put on a lot of weight, they increase the size of their belly. Right. They put it on in here, and as they put it on in here, it increases the pressure inside your abdomen. So obese patients carry, like if you put a pressure sensor inside your abdomen and just measure how much pressure's in there, it's averages around like less than 10 millimeters of mercury. But for very obese patients, it can be up to 15 or more. Yeah. So if you increase the intra-abdominal pressure, well, then that's just more pressure that's going to push the fluids up the wrong way, up the esophagus, out of the stomach. So
gotcha. Is there an age association here? Just getting older and weaker, your tissues getting weaker?
There is. And there's an age association with all hernias too. Like all people, hiatal hernia is part of that. People who have a hiatal hernia, as they grow older, it gets worse. But even if you don't have a hiatal hernia, your muscle tone gradually diminishes as you grow older. So the tone of the lower esophageal sphincter gradually diminishes somewhat. And eventually it gets to a point where it's inadequate to keep the stomach digestive fluids down, and then they can start to come up.
Yeah, now I saw some recommendations for a low-fat diet that may work for some people. I always see these recommendations for whole grains, which I have a whole problem with. But I did see a study which showed that rice was much better than wheat. There may be something particularly irritating about wheat, and that you might think that fiber is helpful or whole grain wheat is good, but there's actual real data to suggest that wheat itself might be a problem. So, and some of my patients, once again, I'm not a surgeon like you, but I find that cutting out wheat is helpful. For the women I treat for fertility. Are there any prescription medicines that might exacerbate heartburn? Any big red flags, any medicines that you guys say, well, you got to stop this medicine because it's causing the problem?
Well, there definitely is an association with the new weight loss drugs.
Yes.
So the new weight loss drugs, because the Ozempic and what's the other one?
The Wegovy and Mounjaro. And they work. Let me just say, these are GLP-1 or other, we're called agonists. And part of how they work, at least, is they keep the stomach from emptying, and it gives you a full sensation, and it makes you not want to eat.
Right. And it's essentially, the way I describe it is it slows digestion. Right.
Yeah.
So if you slow digestion, then the stomach retains fluid more, and the pressure in the stomach is a little bit higher, and that increases the reflux. And essentially, that when people have heartburn, they have GERD. What the problem is that the lower esophageal sphincter, where it joins the stomach, is supposed to function as a mostly one-way valve. So let the food down and then hold closed to keep all the digestive fluids down. So that's kind of the way it's supposed to work, right? And in a person who has GERD, what's happened is that the valve isn't holding very well. And it lets food down, but then it also lets digestive fluids up. And most of the medical treatments of GERD are efforts to try and reduce the potency of stomach acid so that the fluid that comes up doesn't burn you so much. So instead of having battery acid burning your esophagus, it's like lemon juice, right? So it's less damaging to the lining of the esophagus, and you don't have the symptoms associated with it. But it doesn't really stop the reflux from happening. It just makes the burning symptoms go away.
It's less irritating.
Right. And that's the mechanism of action for all these treatments. And all of these diseases that we were talking about that sort of are contributing to the development of GERD are things that are increasing the pressure on the stomach side of the equation or relaxing the pressure on the esophagus side of the equation, so that you're weakening the esophagus' ability to hold, or you're increasing the pressure in the stomach so that it's more forceful upwards. And any of those things that causes that is going to contribute to some extent to your GERD.
So some people taking these GLP-1 medications might have side effects so bad they have to stop.
Right.
I know with surgery, this is a recent alert with so many people on these medicines. The recommendations are that patients stop these medicines 1 or 2 weeks before surgery, because in surgery, we want an empty stomach. We go to great pains to keep the stomach empty, because when you're asleep, you can vomit and it goes down your lungs, and it's a disaster. So this is another maybe originally unanticipated contraindication or side effect with these medicines. So let's say a patient has making some dietary changes, doesn't seem to help. They're taking some over-the-counter medicines, not helping. They can't sleep on enough pillows. The problem is bad. So they go see Dr. Gerber. What are you going to do to see what is the problem? How do you diagnose GERD?
So, first the thing to do usually is you see your primary doc first, and they're going to talk to you about it, and then they're probably going to start you on a medication that you're going to take on a regular basis.
So you get the referrals usually from the primary care doctors, the advanced practice folks that we all need and depend on. So you're going to get people they can't control with medicine and lifestyle changes. Okay, so you've already got what's called a bias sample or selection of people who are going to have the worst problems. Okay, so what do you do with somebody who's been through primary care, they can't get a hold of it, they can't get a handle on it, and they come to you?
So when there are a couple different thoughts. One is, when a person is got bad heartburn symptoms and they're taking all these anti-acid medicines and they don't help at all, I worry that they have one of these other mimicking diseases, because there are a handful of other diseases that feel all the world like heartburn but aren't.
Oh, what are those?
If you take medications for heartburn and they don't help at all, then it might not be heartburn. right? There are esophageal motility disorders where the esophagus is sort of supposed to function in this kind of milking fashion where it sort of milks food down.
These waves come down. It's called peristalsis.
Yes.
Okay.
And if your peristaltic maneuvers aren't well organized and they cause cramping or they don't relax properly or they're weakened substantially and they can't propel food in a normal way, those can cause lots of symptoms that are they're essentially indistinguishable from heartburn. Okay. And then there's other possibilities too, where the visceral pain sensors inside your body. So your brain knows really good where your skin is, right, and your arms and legs. So if something pokes your leg, you're like, that was my leg,
right?
But your
mapped.
Internal organs are all poorly mapped. That's why sometimes a person has a heart attack and it's like jaw pain or arm pain. The heart's not in the arm, right?
Right.
But they feel the pain in here, right? So the same problem affects the internal gastrointestinal organs. And sometimes people will mistake gallbladder symptoms for heartburn, for example. So you might be saying, "Oh man, every time I eat something, I get this pain. It's in here, and it comes through to my shoulders." And it turns out that it's not heartburn at all because you take all the antacids and it doesn't help because it's actually a gallbladder attack, right?
Gotcha.
So whenever a person comes to me and starts telling me that they're having these terrible pains and they've been taking lots of antacid medicines, it doesn't work. The spidey sense goes off. That's like, well, maybe we have the wrong diagnosis, right?
Yeah, you have a broader net, bigger net.
So if it makes sense and we're really chasing after reflux and, gastroesophageal reflux disease as the cause, typically the first step is going to be to get that patient into gastroenterology to get an endoscopy done, to examine the lining of their esophagus and their stomach and to make sure there's not any other things going on. Is there any tumors? Do they have Barrett's esophagus, which is a severe manifestation of GERD that could eventually lead into cancer? It's kind of like polyps in the colon. Sometimes it will eventually lead into cancer. Well, Barrett's can similarly eventually lead into esophageal cancer. So we always have to have that checked, and then
so that's an important thing to realize. We're part of a team.
Yes.
That you're not doing the upper scopes, upper GIs they're called, but you're working closely with the gastroenterologists. Yes. Gotcha.
And the majority of my patients, honestly, come to me from gastroenterology because the primary care doctors oftentimes are going to send their patients who are struggling with reflux symptoms to GI for a scope first. And then after GI sees them, those guys, they here in Columbia and specifically at Boone Hospital, we have a really great GI group and they are busy. They see, so every time somebody's, getting an endoscopy done by them, they're getting a guy who's seen tens of thousands of scopes, right? So they know what normal is supposed to look like and what really abnormal looks like and what it's kind of weird, and they have a very good sense of the spectrum of normal human physiology. So when they see something that looks like it needs, to be discussed with a surgeon, they're always right.
That's great. That's great. So the experience of your gastroenterologist is very important, and I'm so glad we have a great team here. Okay, so they're referred. The gastroenterologist can't fix it. They have a feeling that there's some GERD or a hiatal hernia or something. Where do you go from there, Ben?
So then I talk with the patient about, what we've got as far as information so far, and have we really nailed down the diagnosis? Do we know what we're dealing with? And then we sort of discuss what the treatments are. If sometimes there's an additional test that might be done. They might need a swallow function test, or they might need a acid test of their esophagus to measure how much acid they're having and those sorts of things.
How do you do that?
That's done with a probe. It's like a little tiny tube, basically, that you swallow down, and it stays in your esophagus for a whole 24 to 72 hours.
Well, you got to wear that for a day? This thing coming out your nose?
Yes.
Oh.
It's not the most comfortable thing in the world. But what you're supposed to do is when you have it in, you're supposed to go and eat all that stuff that makes your heartburn go bananas, right? And we're going to measure how bad is your heartburn, right? So you go out and you have the pitcher of beer and the pizza and the whatever else it is that makes your heartburn horrible.
The known offenders, okay.
You go and trigger it, and we're going to measure but usually I'm doing that in an instance where I have some sense of uncertainty as to whether or not the person really has heartburn as the explanation for their symptoms. If that test shows you've got really bad heartburn, then I can be very confident that correcting your heartburn is going to make you better. Whereas if that test shows your heartburn's okay, a little bit, but not really bad, then I can say, if I do a surgery, it's one thing to do the operation, but it's important that when we do the operation, we have a reasonable expectation you're going to get better as a consequence.
Yeah, nobody wants to do surgery without a good prognosis or a good chance for cure.
That it's going to make a difference for you.
Right.
And you're going to go through all the recovery and the pain and the risks associated with it. And you go through all that because you want to get better and you have reasonable hope that it's going to happen. So sometimes we need these tests to help us understand that that's our expectation, that you're going to get better. Sometimes we don't, depending on what we find. And that's where the details of the consultation in the office really sort of helps to suss that out. And then I help educate the patients about what a recovery would be like and what the different kinds of surgery can be done to employ and kind of risks and benefits of each of those. And we can kind of figure out what they want to do.
Well, that's exactly what I want to talk about next. But I wanted, without leaving the medicines behind, I want to talk about that these proton pump inhibitors, these purple pills and all this kind of stuff, they work really, really well by the mechanism you already explained, but they can have long-term health problems, side effects, and really significant health problems in people who take them over. And you mentioned that the over-the-counter box says 2 weeks.
Right.
Well, I see people taking them for years and years and years. And they need to realize that they have side effects. They impair nutrient absorption. I even wrote this down. They are now being associated with dementia, kidney disease, bone fractures, heart attacks, stomach cancer, all kinds of things. Once again, these are associations. It doesn't mean it causes it, but these are things that are not trivial. And believe it or not, in the infertility world, we may see poor sperm counts in guys who've been on these a long time. So being able to treat the symptom, this is my segue into the surgery part. Even if you're controlling your symptoms with these medicines have side effects, and it might be better to fix the problem, the anatomy problem, so you can get off these medicines. Yes. Isn't that true? So if you fix the problem with the surgery and you've selected the patient appropriately, and I'm going to say right now, you're an incredible surgeon. I've actually seen you do these surgeries, and you're just meticulous, and I love it. You operate like I do, so of course it's good.
Right.
So being able to cure the problem, I don't want to say once and for all, but durably, you can get off these other medicines, can't you, sometimes or frequently?
Yeah, I mean, there have been studies looking at this, and something about 90% of patients, about 2 years out, will no longer be taking any anti-acid medications.
Wow.
If they have, heartburn and then they get one of these surgeries. And then the durability of it is another sort of detailed question, exactly like what problem did they have at the beginning, and then what surgery did we employ, and depending on what surgery we employed and what problem they have, some of these things can be durable for 25 years and some of them are durable for less. Those are details that we have to, it gets really into the weeds, but talk that over with each of the patients about what their particular case looks like.
So these procedures for GERD that you're doing are evolving, like all aspects of surgery. We're doing it through smaller holes. We're doing it through minimally invasive routes. Can you kind of take me through the history of surgeries?
Ooh, I love this. This is so
surgeries
fun.
And take us through. Yeah. I assume I'm ignorant about this, so that's why you're here. I know there's something called a Nissen, and was that done through a big incision in the old days? Yes. So take us from the big incision days, and we're going to end up with the incredibly elegant procedure you're doing nowadays.
So the story of the invention of these heartburn acid reflux surgeries, I think, is really kind of illustrative of what surgery used to be like and how surgery has changed over the last century. So there was a guy named, Dr. Nissen, and he trained in Europe in an era long before any anti-acid medications really existed. Okay, and when he was in his training, he remembered an instance where there was a young patient that had a really severe perforation of the esophagus, distal esophagus at the GE junction as a consequence of peptic ulcer, acid ulcer. And
this is a hole in the esophagus. Right. This is bad.
Right. And this is long before laparoscopic surgery. So they did, open surgeries for this. And they had to actually, because the esophagus was so badly damaged, they had to remove a piece of esophagus. And the esophagus is infamously bad at healing in its attachment to other things. So, as a sort of segue here or side point is that if you do esophagectomy surgery where you remove a piece of esophagus for cancer and try to sew it back together again, there's a very high risk profile that attachment where you sew it back together will leak. And then it's a really difficult aspect of that. And that's why there are thoracic surgery specialists. And back in the era of like the late or the early 1900s, when all of this training was happening, they didn't have a lot of treatments for people when these leaked. Their patients would usually die. So the surgeons were worried about this possibility of leaks. So they invented something while they were in the operating room. And at this time, Nissen was a trainee, right? And they basically just folded the stomach around. They re-sewed the attachment of the esophagus to the stomach, and then they folded stomach around it, and then they stitched all that around so that the attachment to the stomach esophagus was surrounded by stomach wall all the way around. And they just used the extra floppiness of the stomach to achieve this. And Nissen always remembered that when this patient healed and didn't have a leak, and when he recovered, he didn't have heartburn anymore either.
Oh, fortuitous discovery.
He was just like, wow, that was so cool. And then years later, when he was graduated and in practice, he performed the surgery on a young woman who just had heartburn but hadn't had a perforation or anything like that. And he did the same thing. We basically pulled the esophagus down and then wrapped the stomach around the lower esophagus and stitched it into position. And he called it the gastroplication, okay, which is Latin for stomach suturing, basically. And this got renamed and modified, and the technique got adjusted, and eventually became what we call the Nissen fundoplication now. And that was the standard of care for a very, very long time.
So it worked.
It worked. I mean, it provided pretty good heartburn, acid reflux control for patients, by what was considered this, quality metrics of the time. Okay, meaning that you had your surgery done, and a month later you don't have heartburn anymore, right? It's great.
It's how surgeons achieve immortality. You get something named after them, the Nissen.
Now, the other interesting little detail is that in the decades that followed, at least 4 variations of the Nissen were invented, where you wrapped it partway, wrap it on the front, wrap it on the back, 370, wrap it 180 on the front, 180 on the back. So I mean, there were all these variations of the Nissen fundoplication that were invented. And one of the things that I find somewhat interesting is that when there's like a lot of different ways of doing something, it's because there isn't really a great way of doing something.
Yeah, I say that, frequently when there's a medical problem, they'll have what's called a consensus conference. They'll bring in people from all over the world. And why do you have a consensus conference? Because there is no consensus.
Because, and if there's one way that's clearly the best way to do it, everybody does it that way, right? Because it's always better.
Standard of care.
But in this particular case, like there was decades of surgical innovation where they were inventing new techniques and trying different ones, and there was other ones that we don't even use anymore. There's the Belzy Mark IV and the Hill procedure. I mean, and these are
Belzy didn't quite make immortality.
Right, I mean, he tried 4 other ones. I mean, there was a Belzy Mark I, II, and III, and they didn't work. And then he became, he published the Belzy Mark IV. And I mean, the point is these surgeries had relatively high risk profile of developing a reoccurrence of a hiatal hernia later. And the Nissen earned a bad reputation because after you did this, you made this one-way valve that was completely one-way. Like you couldn't burp or vomit or anything.
You couldn't vomit.
Nothing would come back up again, right? So the patients would consequently get kind of bloaty and kind of gassy. And in that era, they were all doing these surgeries open. And some of them were being done through chest incisions. And, there was a lot of different innovations. And then when laparoscopy came into existence, in the sort of 90s.
When the gynecologist taught the general surgeons how to do it. Yeah.
Yeah.
I love that. Okay.
And then the Nissen fundoplication was the technique that got modified to laparoscopic repair. And then laparoscopic Nissen fundoplications became sort of the standard of care for managing bad reflux disease and heartburn.
So you can go with the telescope, take the top of the stomach, this floppy part, wrap it around, stitch it in, do it all through a telescope.
Correct.
Okay.
Yep. And then, that essentially fell out of favor with the invention of PPI, the proton pump inhibitors, and prilosec and omeprazole.
So medicines could hold it off and had results that were comparable.
And you didn't have all the bloat and the gas and the nausea, like the issues that would come as the side effects of surgery. Because surgeries, like medicines, sometimes have side effects, right?
Sure. Nothing is risk-free.
So in the opinion of most of the physicians of the world, it turned out that for most patients, they would do better on an antacid medication than they would with a Nissen fund application. And it was really only patients who had severe disease who would get the Nissen fund application if it was poorly controlled on anti-acid therapy.
Okay.
And that was sort of the standard situation and for quite a good number of years. And I would say probably over the last 10 or 15 years, it's begun to become where our surgical techniques have more options, less side effects, less risk of long-term problems for patients. And we're becoming a little more knowledgeable about the potential long-term side effects of being on anti-acid medication, PPI specifically, for decades. So then when you run across a 40-year-old patient who's potentially looking at 40, 50 more years of life taking an anti-acid therapy, maybe the surgery isn't, maybe it looks a little better than it did before.
Right.
And the other detail is that our surgical durability has improved. That there were a bunch of publications that came out in the 80s and 90s that said if you had a hiatal hernia and you had a Nissen fund application done to repair that, there was about a 50% chance that within 5 years your hernia would be back.
Wow, that's a big failure rate.
So with a failure rate like that, it's a reasonable thing to say, well, surgery isn't really the best option unless you're cornered. And now I think our surgical technique has improved enough that we're looking at recurrence rates for some patients. If we can use a Lynx device, for example,
I want to get to that at the end. I want to save that for the end, Ben.
Okay, we'll get into that in a little more detail. But those patients have a risk profile for hiatal hernia recurrence. In some studies, it's like around 4 or 5%. And then, and that looks a lot better, right? And then the modern type wrap approaches have recurrence rates that's probably closer to the 15% range rather than the 50% range that we were looking at it before.
Now, did the advent of the robot have something to do with your ability to more dexterously or more accurately or maybe in a more complex way fix these problems?
I do think so. I think that it's really important to use the robot for this because of a couple different details. Like the way the robot, it has so many little technological enhancements attached to the use of the instrument. I don't know if I've kind of talked about this before, but like when you move if I'm using the robot and I move my hand 2 inches, the tip of the instrument only moves 1, right? And it cancels your physiologic tremor. So if you have a little bit of a tremor, it like cancels it away. It has a magnified view. So when you're operating, you're literally like working through a microscope.
Interesting. Now let me explain what the robot does. We still do a lot of surgeries. So you make a little hole. You go into what we call sticks. I still operate with sticks. So with the robot, we're still going through small holes, maybe a little bigger.
They're 8 millimeter trocar.
They're 8 millimeter. Mine are 5. But anyway, they're 8 millimeters. It's the idea is still the same. It's tiny little holes. It's minimally invasive. Correct. But now instead of using sticks and trying to fumble with 2 dimensions, you can now get in and have a wrist and have 3-dimensional control. So, and the other benefits you mentioned.
They call it a robot because it has a little mechanical hand, essentially, that goes in. And it's a tiny little thing. It's only 8 millimeters in diameter. But essentially, it has the same range of motion as my own hand does. So it's a much more dexterous instrument. And the advantage that gives to me as a surgeon is that when I'm working in a small place, I can use the forearm of the instrument. Does that make sense to you? Kind
of push a little bit.
I can hold things away, and I can still have full dexterity in the center between. Whereas with laparoscopic instruments, you need another poke hole in here with a different instrument to hold that up because you can't use the tip of my instruments and the forearm independently.
Right.
And this becomes particularly relevant if you're way up inside a small place.
Yeah.
So the urologists use it with great dexterity
with prostate
because it's a very tight space low down in the pelvis. And the hiatal hernia, it's very similar because it's a small hole in the diaphragm, but there's all this stomach up in the chest behind the heart with the pulmonary arteries and the esophagus and the aorta and all this high value real estate up in here, right?
Well, I'm sold. I'm sold on it. You got to
pull the stomach down and deal with all this stuff and be able to work in there. And it's very useful to have that forearm that you can use to hold away, but still use the tips.
So the robot, when did you start using a robot in your training? For about 10, 15 years now?
I started some exposure to it in residency. I think I did about 25 or so robotic surgeries.
But I'm just sort of looking for a time scale here.
Yeah.
So it was about 15 years ago. It really came online, or maybe
for general surgery, it was around 2015.
Right, so it's been about 10 years,
yeah.
10 years. So that was a huge technological advancement. Yes. You're able to do these wraps better, these hernia repairs better, get more durable results, but still left a little to be desired. There was room for improvement.
Yeah, I mean, and I think the key detail is the recurrence rate, right? And what can we do to try and minimize the risk profile that this patient's ever going to need to have another operation for this problem?
Well, that is the perfect segue into this procedure that you're doing nowadays, Ben. You're getting very famous for doing it. Your caseload is, and if anybody knows anything about surgery, the more a surgeon does, generally the better they get at it.
That's true.
It's like airline pilots. Yeah. What is it? They rate how many hours do you have on this Airbus? You know, it's time and experience. So, tell me about this latest device procedure that you have to treat GERD surgically that has this very low recurrence rate, very high success rate.
Yes.
And once again, I've seen you do, and I think it's just amazing. Please tell us about the LINX.
Okay.
I think it's LINX.
That's correct. So LINX it's a relatively new innovation. They got FDA approval in 2012. So they've been around more than 10 years at this point. And what the device is, essentially it's a little necklace of magnetic beads. And each magnet sort of aims at the next one around the circle. And they're all connected together like on a chain. But what they do essentially is their magnetic attraction is fairly wimpy. So that when you swallow, your swallow power should be enough to pop them all apart and let the food down.
To saturate.
But the normal digestive movements of the stomach are not powerful enough to pop them open and allow acid to go the wrong way. So it sort of tries to set in this happy medium between the digestive power of the stomach itself and the swallow power of the esophagus.
Goldilocks, just right.
Exactly. And it when it was first FDA approved and the studies were done to look at this, it had a very good success rate with respect to controlling heartburn and acid reflux. And the real value, I think, of LINX that came into like awareness of the surgical community later was that when you used it as part of your hiatal hernia repair surgery, it had this unanticipated and quite nice side effect of reducing the risk profile of the recurrence of the hiatal hernia down the line. So I'll kind of back this up just a little bit. So when a hiatal hernia is one of the most, like, from a surgical perspective, it's one of the reasons that I most often will employ surgery to correct heartburn, because when people have a hiatal hernia, they usually have heartburn that's relatively difficult to control, and we know that their hiatal hernia will gradually worsen. So when you do that surgery, it's been established through probably at least 50 years of surgical research that when you do that surgery, you can't just pull the stomach down and then call it good. You have to also do some kind of anti-reflux surgery as part of it, because it substantially reduces the chance of recurrence of the hiatal hernia. So for a very long time, the standard treatment was to perform a Nissen fundoplication. You'd pull down the hernia, you'd stitch up the hole, and then you would perform a Nissen fundoplication. And that was kind of how you conducted the surgery. Okay. So in the early 2012 sort of range, within the few years that followed that, there were surgeons who were saying, well, instead of the Nissen wrap, let's use this LINX thing. So we pull down the stomach and we stitch up the hole in the diaphragm, and then we put this LINX thing on. And, well, what happens? Do the patients, how do they do? And they, as it turns out, they do better than the Nissen patients did. Because the
LINX this has been done. This has been prospectively analyzed in a real study.
It's been retrospective studies done.
Okay.
But
they can work. They can be powerful.
Have been several different ones done that have shown the same, very close to the same outcome. That it's like right around 5% risk profile that the hiatal hernia would reoccur.
So that's amazing. So it's gone from a 50% recurrence rate to a 5% recurrence rate. That's spectacular.
And that's, I think, for me, that was, I'm sold. And I can't use LINX for every patient because I can't modify the potency of the magnets. So people who have a weakened swallow power for some reason, which is a common thing for people who've had GERD for decades and swallowing trouble, and who've maybe had a very abnormal esophagus because their hiatal hernia has been growing for a long time. at least a third of the patients I test their swallow power find that there's something abnormal about it. And I can't employ links for them.
I assume the links people know this. Maybe they could have a different strength lengths.
Well,
isn't that
if
interesting?
they turn down the strength too much, then the reflux becomes more of a thing. So
it's a harder sweet spot.
It's a sweet spot, biomechanics kind of thing. And
so what does the links look like? Because it's got to wrap around.
Yes.
We should have brought one. Is it like a straight thing that you then can hook together? How do you do that?
It looks like a tiny little bracelet that's about as big as my wedding ring.
Really?
And it's beads. Okay, and then one of the beads has a clasp, so it separates.
It's like
apart.
a necklace, and you just hook it together.
So you slide it in through one of the trocars, and then I went up from the inside. I'll position it to encircle the esophagus. So, we actually measure the diameter or the circumference of the patient's esophagus to see if it's appropriate size, because there's several different sizes.
Can you? There's different sizes.
So
okay.
it's like how many beads in the circle, basically, and they've got a variety of different sizes that the manufacturer has made available.
Like the orthopods.
Exactly.
How big is your socket? They got a socket that size.
Exactly.
Okay.
Yes. And then so we measure the diameter or circumference of the patient's esophagus, and then we bring in the appropriate size links device. We click it into place.
And you click it into place, and there you go.
And then you're done.
Now, do magnets wear out?
No. So in general, magnets can wear out, but these are neodymium magnets that they use, and neodymium magnets will last for hundreds and hundreds of years.
Is that a rare earth?
That is correct.
That is a rare earth, as you said. How do I know about them? Because I remember the shows look for meteor hunters.
Yes.
People will go through the desert of Chile.
Yeah.
They'll drag one of these magnets behind them and collect the meteors around, right? Because they're so powerful. Now, what's this about magnets being dangerous to swallow or with children? I always thought magnets were dangerous.
That is a big deal. Okay, that's a totally separate thing altogether.
Well, tell me about that.
Okay, so I'll make the little comment that doesn't really apply for the links device because the way the magnets are all connected to each other and they're not inside the gastrointestinal tract. They're outside the gastrointestinal tract and they're positioned and like anchored in their place.
And they're not going anywhere.
So they're not going anywhere.
All right, that device it keeps them in check and where they're supposed to be.
They're not going to move around. Right. But this other issue of magnets is sort of mostly important for parents, frankly. Because there was an era of time where there was when these neodymium magnets first came around, people, toy makers would make these kind of creative little toys that were made out of lots of little magnets, and you could position them and make like a horse or a figure out of these magnets. You buy a pack with like a
magics are miraculous for kids.
Right.
Huh? They're still fun.
So, and what would happen is if a child would swallow one, and then maybe a little while later swallow another one, you can get these magnets floating around in the gastrointestinal tract. And if they get close enough to each other, they'll stick. Now, if they're still inside the same piece of bowel, it doesn't matter. They just poop them out. But if they're in two different loops of bowel, they will attach across the wall of the bowel, and they will pull each other with such power. They will eventually rupture, make a hole.
They'll
in
eat
the
through.
intestine.
They'll kill that intestine and necrosis.
Basically, it's like a pressure ulcer that they'll
perforation,
and they perforate the intestine, so then it begins to leak inside, and
you die.
Yeah, that's dangerous. People will die.
So
from that.
that's what. So it wasn't the magnetism itself. It wasn't the neodymium. It was the physical aspect of having out of control magnets pulling parts together.
And then becoming a perforation, pinching the intestine between them and perforating.
Okay, I see the difference. Thank you for clarifying that. So tell me, this Lynx device, you're doing this more and more often now, aren't you?
Yeah, it is. It's we're probably on track to do over 100, probably around 150 this year. Not necessarily everybody for Lynx, but for hiatal hernia repair.
That's you personally?
That's me personally, yeah.
Wow, that's every other day, and I'm assuming you're doing a few in a day. And
yeah, we can get
about
lot. 4 done a day when we have an OR day, and we get 1 OR day a week.
Wow,
so that's about what we're doing.
So you're getting a lot of experience doing this, Ben. So I know Boone Hospital is advertising this
I'm
because
very
you're
appreciative.
because you're getting so good at it. And tell me all the great stories, all the happy customers. Tell me what do people tell you afterwards? Can they go back to the Chilean beer and whatnot?
Almost all the patients come off their antiacid medicines, and that's important to a lot of people. They really like being able to do that.
And the fertility doctors, like I said.
The other thing that I think is most people really talk about is that they sleep better. Because many of these patients who have hiatal hernia wake up choking and stuff, and they use pillows and sometimes CPAPs and things like this to try and help address this problem. And when their heartburn's gone, it's like your sleep quality is so important to your general life. And
your depression, even obesity, all these things get better when you get better sleep. Your muscle tone, everything gets better.
So that, I think, for as far as like the happiness that people have when I see them in recovery, in the like 2 weeks out, that's the thing that most commonly out here is like, oh, I'm so happy I do this because I sleep so much better than I used to. That's I think that's really fun. To see.
Dude, that's why we do this. Yeah. We're doctors because we like helping people and make the world a better place. And so you're seeing real. It's not just some nibbling at the edges here. You're seeing profound changes in their life and their quality of life.
Yeah.
In patients, and once again, not for everybody, those that you appropriately find that you've selected out, those that are the candidates for this.
And for the most part, we're managing. I mean, these patients almost all of them have maneuvered their way through being seen by a gastro doctor. They've tried medications. They've been diagnosed with some. Usually, it's a hiatal hernia or some kind of anatomic problem. And then occasionally we'll do it for patients who don't have a hiatal hernia. But and then those people have been found to need something done, basically.
So there's a tremendous need, you're filling it, and you're getting tremendous results. So once again, this is Dr. Ben Gerber, fantastic general surgeon, specializing now in what's called foregut. The mouth is the fore, the bottom is the aft. Sure. You're specializing in the foregut up here. Tremendous experience, and now you're using this Lynx device to help hundreds and hundreds of people.
Absolutely.
Well, what a pleasure talking to you about this, Ben. Thank you for all you do. Thank you for your time. And what a pleasure it is talking to you yet again.
Absolutely. Thank you.